Venous thromboembolism is a particularly important subject. And whenever you practice in clinical medicine, especially adult clinical medicine, you will be faced somehow with a patient who suffers from a venous thromboembolism problem. So this is not very specific to medical doctors. On the opposite, surgical, gynecological, obstetric, orthopedic physicians, etc., are faced with this problem among the patients. So the objectives of this lecture is to address some of the risk factors for pulmonary embolism, the clinical presentation of deep vein thrombosis and pulmonary embolism, a diagnosis by labs and imaging, talk about hereditary and acquired thrombophilia, and talk about the treatment, either short or long-term therapy, and the prognosis and prevention. We'll start with a case. This is a 35-year-old woman who is previously healthy. She presented emergency room with painful left leg swelling of 3 days earlier. She denies fever or trauma to her leg. She also has new dyspnea and chest pain with her presentation that she did not have before. She has been taking oral contraceptive pills for the last 6 months. On examination, her blood pressure was on the low side, her heart rate was high, 124, respiratory rate high, 32, and she had temperatures normal. Leg examination, the whole left leg was swollen, red, and tender. It was 4 centimeters different from the other leg. And chest examination was normal. And her cardiovascular examination, the heart, she had tachycardia, which is irregular. So this patient has an acute unilateral leg problem, and she has a new onset of cardiorespiratory symptoms of dyspnea and chest pain. So our provisional diagnosis would be mostly acute deep vein thrombosis that is complicated by pulmonary embolism. And these two disorders, because they are so connected with each other, we call it a venous thromboembolism. So this patient had a VTE, or venous thromboembolism event, and acute. The differential diagnosis for acute leg swelling that's unilateral is usually a deep vein thrombosis, but infection like cellulitis or a ruptured Baker cyst or trauma to the muscles, to the bones, to the soft tissue can cause such presentation, or post-operative changes, let's say total knee replacement, can give you a similar, or a hematoma. So not every unilateral leg swelling is deep vein thrombosis, but it should be on the top of the differential diagnosis. That's why several people looked at risk stratification or probability scores for deep vein thrombosis. And one of them is very known as Wells probability score for DVT. And if you look at the score, if you have more than or two these findings, then there is a likelihood that you have DVT, but if it's less than 2, it makes it unlikely. And if you look at him, active malignancy, paralysis, paresis, recent immobilization, the presence of localized tenderness along deep venous system, entire leg swollen like our patient, calf swelling more than 3 centimeters larger than the asymptomatic site, our patient. So here, entire leg swelling, she has more than 3 centimeters is 2. Pitting edema is 1. Collateral superficial vein or varicose, non-varicose veins though, and previously documented DVT. This is not the first event. Alternative diagnosis is unlikely. The presence of alternative diagnosis is there, so give you a -2 points. Let's say, well, the patient has fallen, broke her leg, or whatever. That gives you a solid alternative diagnosis. But the Wells criteria just gives you the probability that it's DVT in the emergency room or when you see the patient acutely. But what you do next? There is a simple test called the D-dimer test. It's a very sensitive for venous thromboembolic events, but it's not specific because other things can cause elevated D-dimer, like say people elderly, more than 70, the cigarette smoker, post-operative pregnancy, some races like black people, and acute coronary syndrome, acute limb ischemia, atrial fibrillation, cardiovascular disease, DIC, eclampsia, infection. For example, recently COVID-19 infection associated with a high D-dimer, liver disease, malignancies, a long list of things that can cause positive D-dimer. So when the D-dimer is positive, it's not very useful actually in the setting of acute DVT, but it has a high negative predictive value. So if you have a patient like this with a hugely swollen leg that doesn't have any other explanation and the D-dimer is negative, that makes the diagnosis of DVT unlikely. So in the outpatient ER settings, it is used to rule out DVT rather than in the inpatient settings where other things can cause elevated D-dimer. But I would use it with caution and rule out pulmonary embolism. So let's stick with DVT. One important lesson about the D-dimer is just positive D-dimer is non-specific and should not be used to think about pulmonary embolism. Now, a definitive diagnostic test should be done, and the most commonly used is a lower extremity ultrasound, where the physician or technician will examine with the Doppler US ultrasound the deep vein system, starting with the popliteal vein and go up. And they do this compression testing because the vein is a low pressure system, so if you compress it, it's compressible. But if there is a clot inside, you cannot compress. So lack of compressibility has a high sensitivity and specificity for pulmonary, for DVT or deep vein thrombosis. And also if you combine it with Doppler ultrasound, you'll see there is no flow in the vein, and that's very helpful. So this is very quick, non-invasive, but it is operator dependent. But the patient also, so we established that our patient most likely has a new acute deep vein thrombosis in her leg, but also she has dyspnea and chest pain, and these has to be explained. I'll show you 3 rules that we use to interconnect DVT with pulmonary embolism. The vast majority of patients with pulmonary embolism, they originate from the lower extremity DVT. So lower extremity DVT is the major source of pulmonary embolism. Now, other sources is upper extremity, and also can come from the inferior vena cava, but the most one is from lower extremity DVT. Again, it can come from upper extremity, especially patients with malignancy, let's say breast cancer, or the ones who had instrumentation, central line placements, or from the inferior vena cava, let's say somebody with renal cell carcinoma. But only 30% of patients with PE have symptomatic DVT. So 70% of patients with PE, their leg examination is normal. They don't complain of DVT. So the presence of normal examination of the legs, the lack of symptoms of DVT does not in any way rule out pulmonary embolism. And up to 50% of patients, half of patients with DVT, like our patient, they have simultaneous asymptomatic PE. So patients with DVT, if you ask them, do you have shortness of breath, do you have symptoms of pulmonary embolism, they say no. They still, half of them, they already have showers of emboli that went to the lung and caused PE. So these 2 diseases are interconnected, and that's why we call them a venous thromboembolic disease. But the way it happens is, it starts as a distal DVT, and the distal, only 20% of them, it propagates to become proximal, and maybe, 30–50% of them, they shower into pulmonary embolism. And sometimes it's small and multiple, and sometimes it's very large embolus and has a huge impact on the patient physiology and presentation. So the clinical presentation pulmonary embolism is non-specific, as you say, but things that makes you think of pulmonary embolism is sudden unexplained dyspnea, pleuritic chest pain, uh, um, cough is rather unusual, hemoptysis, frank blood is not common, but it makes you suspicious, and symptoms of right heart strain with syncope and dizziness. But if you look at the data on patients with acute embolism, they can be asymptomatic, as we said. 50% of patients with DVT, they have asymptomatic PE. You do imaging studies, you accidentally find it. To a post-mortem finding, the patient die unexplained death, you do a post-mortem examination and find they have a massive pulmonary embolism. Some of the common symptoms of pulmonary embolism that students like to correlate strongly with pulmonary embolism is, for example, hemoptysis. Only 8% of patients with confirmed PE, they have hemoptysis in one study compared to 4% with no PE. So hemoptysis is uncommon. But the common symptoms are dyspnea, for example, 50% of them, cough 23% of them, pleuritic chest pain 40% of them. But if you compare the ones with or without, and these are large numbers of patients, you'll see no differences. For example, dyspnea 50-50, pleuritic chest pain 40-28%. So these symptoms are non-specific. So how then I will diagnose my patient? Well, physical examination, again, also non-specific. Tachypnea, tachycardia, hypotension, low-grade fever, fourth heart sound, accentuated P2, signs of pleural effusion, all non-specific findings. So, again, how would then I reach the diagnosis? Is my symptoms are not specific, my physical signs are not specific. What about, well, the criteria of probability? Here are another probability score that we can use. For example, this one, if you have a leg swelling and tenderness, give you 3 points. Tachycardia, immobilization, recent surgery, prior VTE, the presence of hemoptysis, presence of active malignancy, and there no other likely diagnosis. So this is very important. The last one that has 3 points is if no other explanation for these symptoms, let's say cough, hemoptysis, shortness of breath, pleuritic chest pain, and on examination they have tachypnea, tachycardia, hypoxemia, and in the midst of all of that, I don't have an alternative diagnosis, then pulmonary embolism is likely. What about the chest X-ray? Chest X-ray should be routinely done for patients with these symptoms and signs, and the chest X-ray is usually done to rule out other pathology, but the chest X-ray is usually normal, commonly normal in patients with pulmonary embolism. Sometimes you will find indications of infarction, atelectasis, small pleural effusion, but the biggest one is a normal chest X-ray with patients who have dyspnea and hypoxemia and without evidence of bronchospasm. They are not wheezing. There is no cardiac shunt. It's strongly suggestive of PE. So I have a patient with normal chest X-ray, but they are dyspneic and hypoxic, and I don't have an explanation for this. That raises the strong possibility. What about EKG? EKG usually also non-specific. Commonly, you will see tachycardia, non-specific STT changes, but they are not helpful with the diagnosis. Occasionally, you will, and we've seen that through our career and practice, and that you'll see this S1, deep S1, and Q wave and T inversion in lead 3, and you'd see that there is a deep S wave in lead 1, there is a Q wave with T inversion in lead 3, and these tend to be more specific with a. But a definitive diagnostic test must be performed whenever pulmonary embolism is clinically suspected. We often get consulted on patients in the hospital to rule out pulmonary embolism, and what we tell the physicians on the phone before even we see the patient, that if pulmonary embolism is suspected, the best thing is to do a definitive diagnostic test, because I don't think a pulmonologist or an internist is not better than a surgeon, orthopedic surgeon, to differentiate between patients with or without pulmonary embolism, especially with risk factors, unless there is something obvious on the We used to do a ventilation perfusion scan. That's a nuclear study that the patients will be inhaling and exhaling a radioactive gas that will give you the ventilation of the lungs. Then will be given in an IV also radioactive material. They will look for the perfusion for any mismatch between the areas of ventilation and perfusion is called a defect because, for example, this area of the lung, there is no perfusion to it. However, the interpretation of the VQ scan is difficult, and it is dependent on the clinical suspicion. Let's say if the physician has a high clinical suspicion, my patient developed acute dyspnea, hypoxemia, his chest X-ray is normal, I don't have any explanation, he just had an orthopedic surgery, then my clinical suspicion is high. If my clinical suspicion is high and the VQ scan has a low probability, still there is a 40% chance that my patient has pulmonary embolism by pulmonary angiogram. But if my high suspicion is met by a high probability, my diagnosis is almost 100%. But if the clinician suspicion is low, I'm not sure that this is pulmonary embolism, let's do a VQ scan. If that is the case and it came to be a high probability, you are lost. You are 50-50 still. This is not very helpful. Half of the patient would turn out to be not having pulmonary embolism and half of them will. But your best bet on when you do a VQ scan is to have a high probability and high index of suspicion, or low probability and low index suspicion, or if you have a normal VQ scan, which is kind of unusual to get. So it is non-confirmatory diagnostic in a lot of cases, and we used to do pulmonary angiogram. Then pulmonary angiogram was replaced when the technology advanced by CT angiography, and the recent advances in the technology of the CT scan allowed us to do something called pulmonary angiography through CT scan. So it's called CT angiography. And what we do is we inject the contrast into a large vein, and the machine will time the contrast to arrive into the pulmonary arteries. Then it will quickly and rapidly scan the pulmonary vessels. So you have to have a very quick scan, and has to have a high resolution scan. So as you see in this image here, this is the left pulmonary artery, and you see it's blocked completely with an embolus that occupies most of the left pulmonary artery and the right pulmonary artery. And if you see it on this section too here, the left pulmonary artery, the right pulmonary artery are completely opacified by this pulmonary embolism, and there is an associated infarction even on CT scan. And also another advantage for the CT scan, if you don't diagnose pulmonary embolism, you will have alternative diagnosis to explain the patient complaints, maybe pneumonia, maybe pneumothorax, pleural effusion, pulmonary edema, etc. So now the standard test for diagnosis acute pulmonary embolism is pulmonary angiography. The only contraindication for pulmonary angiography is if the patient has renal impairment or allergy to the contrast material. Now, once you establish a diagnosis of DVT and or pulmonary embolism, the treatment is usually anticoagulation. Anticoagulation is meant to prevent the further propagation of the event that already happened, stop the propagation of the event, and stop the recurrence of the events, because the recurrence could be fatal or has higher morbidity. Thrombolysis is best reserved for severe cases of pulmonary embolism and deep vein thrombosis, and we only give it for patients who are hemodynamically unstable or show huge compromise on cardiac function by echocardiography, or patients who have massive deep vein thrombosis that may compromise the blood supply, or patient have severe intolerable pain. Some patients who have contraindication for anticoagulation thrombolysis or thrombolysis, we insert an inferior vena cava filter into the inferior vena cava to prevent the recurrence or the happening of pulmonary embolism. It does not prevent the recurrence or the propagation of the deep vein thrombosis, but surely it will prevent and highly prevent the occurrence of pulmonary embolism. But these filters should be on temporary basis and only when there is an absolute contraindication, temporary indication for anticoagulation. In the acute phase of the event, when the patient is diagnosed, we usually give subcutaneous low molecular weight heparin, enoxaparin or tenzaparin or whatever available. That's what we have, at least in Jordan. And these, they don't need to be measured. Measure a PTT or PT to follow them. These are weight-based fixed dose. For example, enoxaparin is 1 milligram per kg twice daily, given up to a certain weight of the patient. And they are effective within 30 minutes of administration. Now, IV unfracturated heparin, it has to be given IV, continuous infusion. It is effective, but you have to measure the APTT quite often to maintain it at certain level. And now even we have newer drugs, non-vitamin K oral anticoagulants. Some of them they have approval for the acute treatment of DVT and pulmonary embolism, like now, this is in the acute phase. The acute phase, most of the patients will receive low molecular weight heparin subcutaneously, and some patients will receive a rivaroxaban or similar NOAC in the acute phase. But the vast majority will receive low molecular weight heparin. Now, this cannot continue for a long time. The patient has to be bridged for a long-term therapy. If they are started on NOACs or non-vitamin K antagonists, they can be continued as the main long-term therapy. These are fixed oral dose, and they don't need to be monitored within the reasonable kidney function or reasonable patient weight. And they can be used as a primary therapy or post low molecular weight heparin. So they can be bridged from a low molecular weight heparin to NOACs, or the rivaroxaban could be used at a higher dose in acute phase and then be followed at a lower dose for the long-term therapy. The most widely used drug is the vitamin K antagonist, which is oral warfarin. Oral warfarin can be bridged with low molecular weight heparin or IV heparin from day one, but you have to monitor the prothrombin time and INR, and to maintain the INR between 2 and 3 in most patients. Maybe in antiphospholipid, a higher INR is needed. Some patients who have active malignancy, studies have shown that they should be continued on low molecular weight heparin for the duration of therapy. Now, for the long-term treatment, we have to differentiate between two kinds of venous thromboembolic events. The provoked ones, that they come after oral contraceptives or surgery or pregnancy, prolonged air travel, hormone replacement, acute infectious or acute illness or leg trauma. These are provoked events. These patients usually, they have a normal thrombophilia profile. Usually, I said some of them do have abnormal, but usually, and these are just provoked events that happen because of this acute immobilization or hypercoagulable state, let's say from oral contraceptives. And we have the ones who have unprovoked DVT. They don't have any of these events. They could have a connective tissue disease, antiphospholipid syndrome, active malignancy, or myelofibrotic disorders, or thrombophilia, the inherited thrombophilia, which later. A choice of anticoagulation therapy uh, uh, for the provoked events. Most of the guidelines now talk about only 3 months of therapy, either with a vitamin K antagonist like warfarin or NOACs, one of these non-vitamin K oral antagonists. But patients who have unprovoked DVT or they have persistent risk factor, they should be on indefinite anticoagulation, lifetime anticoagulation, if their risk of bleeding is not high. Now, recent recommendations for safety and easy of administration. I think NOACs like rivaroxaban, apixaban, etc. are favored over warfarin because they don't need to be monitored. And they are favored over low molecular weight heparin because they are easy to administer. These are sub-Q injections. The vitamin K antagonists, they need to be monitored for PT on regular basis. And why we give only for 3 months for provoked and we give indefinite for unprovoked DVT because of risk of recurrence. If we look at the provoked by surgery, there's a 3% recurrence at 5 years. It's very low. But VTE provoked by non-surgical transit risk factor, for example, estrogen therapy, pregnancy, leg injury, prolonged flight, they have still a higher recurrence rate at 5 years. And that's when I said these patients not necessarily have a normal thrombophilia profile. They could have a hidden thrombophilia because they have a higher recurrence rate. But idiopathic VTE, they have almost a 30% recurrence at 5 years, higher in the first year or after the event. And these are the ones that should be definitely anticoagulated for a long time. And VTE with cancer has probably the highest risk, which is 15% on annual risk of recurrence. It depends on the survival of the patient. Now this is a picture of the commonly placed IVC filter. If you see, it has a hook on the top, so the interventional radiologist can easily place this into the inferior vena cava and leave it there for the temporary period that is needed. For example, a patient has a GI bleed or intraocular hemorrhage, you cannot put him into anticoagulation. Now this event has resolved. Anticoagulation now is safe. After 2, 3, 4 weeks, the patients will come back to the interventional radiology. They grasp it by the hook and remove it because it can penetrate. The inferior vena cava can penetrate the wall and can become sticky and difficult to remove. It can form clots around it and a blockage on the inferior vena cava. So it should never be left there if there is no reason, strong reason. Now we talked about it from a patient perspective. Now I'll talk about general slides about pulmonary embolism, the importance of the disease, etc. It is, first of all, it's a preventable disease, and in the hospitals now we work hardly on establishing guidelines and protocols for physicians, a surgeon, and orthopedic, etc., to prevent this from happening. For example, in Jordan, we're expecting to see up to 22,000 cases per year. And believe me, we do see that. This is common in our practice. It is a major cause of disability. It can cause pulmonary hypertension, chronic thromboembolic pulmonary hypertension. It can cause post-thrombotic syndrome, and this is very common among especially women. Persistent leg swelling, persistent skin changes, persistent leg pain, especially with standing. And this is the most common complaint that I get from patients who had DVT, especially females, about this post-thrombotic syndrome. It can be fatal up to 30% of cases within the month of occurrence. So up to 34% of them, they presented with sudden death, fatal PE, 60% of the deaths resulting from undiagnosed, and 70% who died after early correct diagnosis. So early correct diagnosis will drop this mortality rate significantly in patients with acute pulmonary embolism. So it's very important to suspect pulmonary embolism in the patient. Pulmonary embolism is unusual below the age of 40, 50. It is usually a disease of the older folks, especially in the Western population. Now, I said it's very important to suspect it in patients who are older than 40. Any one of these risk factors, and this is the virtuous triad, they talk about endothelial damage, let's say smoking, hypertension, surgery, catheter placement, trauma, hereditary like factor V, prothrombin mutation, protein CS, acquired thrombophilia like cancer, chemotherapy, hormone replacement therapy, pregnancy, obesity, heparin-induced thrombocytopenia, stasis, which is prolonged mobility from ICU, mechanical ventilation, acute medical illness, polycythemia, long travel on airlines. These are all risk factors of VTE. And here are some of the, also another list of risk factors that you should go over and understand that these patients are at risk of VTE. So the profile of the patient is important. More than 40 has one of these risk factors that unexplained respiratory symptoms of dyspnea, of chest pain, hypoxia, tachycardia, tachypnea, not explained with the background of these risk factors, increases the suspicion for pulmonary embolism. So doctors should have high index of suspicion when they deal with patients with pulmonary. Few words about the risk factor. Cancer is a common predisposing factor. Oral contraceptive use is frequent predisposing factor in the age group of childbearing. Pregnancy is a major cause, PE is a major cause of morbidity and mortality in patients who are, in women who are pregnant. And the risk is highest toward the end of pregnancy and right after delivery. And we see quite few patients after delivery, especially if they had cesarean sections with major events. And you hear every once in a while of women who just had their babies and found suddenly dead at home, and that's probably pulmonary embolism. And another huge group of patients is acutely ill medical patients. And if you go now to the wards and on the 10th floor and look at our acutely ill medical patients, you see that low molecular weight heparin on the dose of enoxaparin 40 milligrams is commonly prescribed for patients to try to prevent this expected complications of illness. Long haul flights, especially more than 8 hours now with the new wide body airlines, that they can travel for 17 hours non-stop, especially in patients who have thrombophilia or previous events. And some of them, they come to the clinic and receive low molecular weight heparin before they get on these flights. You expect thrombophilia in patients who are young, less than 50, who have unusual location, upper extremity, for example, inferior vena cava, iliac veins. Patients who have massive DVT, massive TB, even with risk factors, suspect the presence of thrombophilia. We had a patient the other day that she had the delivery of her baby and she had a massive DVT that she received thrombolytic for it. And everybody was saying this is related to her delivery of her baby. And no, when we looked for a thrombophilia profile, she had antiphospholipid syndrome. Also, unprovoked DVT, de novo DVT or PE should make you suspicious of thrombophilia. Recurrent events and a family history, especially in close relatives, siblings, and parents. These are some of the common thrombophilia, inherited thrombophilia. The most common probably is the factor V Leiden, which is the G1691A mutation in factor V gene, mutation in the prothrombin gene and the MTHFR gene. Uncommon or rare antithrombin deficiency, protein COS, we don't see here in Jordan for some reason. Homocystinuria you see sometimes. But what would you see mostly is the MTHFR and the factor V Leiden. Here is the inherited thrombophilia and the risk of recurrent VTE, factor 5 is like 50% recurrent prevalence of recurrence VTE. So that's why we concentrate on factor 5 Leiden when we examine for thrombophilia. Post-thrombotic syndrome, we talked about it previously. That's very common, very disturbing, and it can be very disfiguring, especially to females. And it's very common with pain, persistent edema, swelling, and hyperpigmentation, skin ulceration. Every time they come to the clinic, we ask about their PT and INR, and she asks about her persistent symptoms. And so far, there hasn't been any effective therapy to prevent or intervention to prevent the occurrence of post-thrombotic syndrome. Many patients with the PE, they recover completely after the event, and if you do repeat imaging weeks after the event, there will be no evidence of previous thromboembolism. As we said, if they are undiagnosed and untreated, mortality can be high. And the overall mortality is around 12% without a diagnosis, but with a proper diagnosis, timely diagnosis and treatment, it is less than 10%. Some of these patients, they develop recurrent PE. Some of them they know about, some of them they don't know about. And with time, they develop pulmonary hypertension, which is very devastating to them with exertional dyspnea and syncope and hypoxia. And they live a miserable life and shortened life. And the also once you have a VT event, there is a high risk of recurrence, and we warn our patients that they should tell their physicians, especially if they're going to have surgeries, that they had a previous VTE. To prevent high-risk population in surgery, we encourage early mobilization and leg exercise, and this should be a common practice, especially for any hospitalized patients. And on the airliners now, they encourage you to mobilize, and lots of apps, travel apps, you have them on your iPhone or Android device. They will send you a notification every once in a while when you are in the flight to get around or move your legs to prevent stasis and the occurrence of DVT. Adequate hydration is important, again, during hospitalization and during long-haul travel. Now we have mechanical devices that we use like elastic stockings or graduated elastic compression devices, which I will show you, or the intermittent pneumatic compression devices. But what we commonly use is we use medications, and we use usually low molecular weight heparin on a fixed dose basis for patients who are at risk in the hospital, especially patients with acute medical illness, ICU ventilated patients, patients with immobility from neuromuscular problems, patients who had specific surgeries like lower extremity surgery, total hip, total knee replacement, it's cancer surgery. So this is a pneumatic compression device. It's connected to this pump that will pneumatically and gradually pump the legs up, and this is combined with elastic stockings. But what we usually do, as I said, in our patients, we use these standard dose low molecular weight heparins on